Good afternoon, everybody, and welcome to COSCON. Hi, sir. Can't hear you. Yes. Guru Prasad, sir, is in scrubs. Good to see you, sir. Hope you're feeling better. Can't hear you, sir. You're on mute. Both of you are muted.
Hi, good afternoon.
I'm better today. I recorded in the morning, early morning, and sent,
Okay.
uploaded. So
thank you so much,
yeah,
sir.
I would
Welcome,
prefer
everyone.
what's to be played now.
This instruction course is basically an update on diabetic retinopathy management. We'll be talking about imaging, talking about AntiWedge therapy for PDR, which is Dr. Hemant Murthy's favorite topic these days. And no, see, he's shaking his head. He doesn't agree with me. And then Dr. Guru Prasad, who's our guru in retina, will be talking to us on how to manage DME patients with good vision. You know, that is a little scary prospect for all of us, but then we have to treat them. We also have Sachin, a good friend of mine from Belgaum. He'll be talking to us about surgical solutions for DR. And finally, Dr. Bhujang Shetty will be talking to us on whether there is a way for us to actually reverse diabetes itself, which will be like half the battle won. And lastly, Dr. Anand from Remedio on whether AI screening can help us, improve management of diabetic retinopathy, or rather screen at an early enough stage. So if the backend team is ready, we can start off with the first video. This will be on imaging biomarkers guiding DME treatment. I thought we can have a quick minute or two discussion after each talk, so that if any of the speakers need to go back to their OPD, they'll be most welcome to. And if the audience or the attendees have any questions, please send it across to us so we can address each talk questions just after the speaker. Can we have the first talk, please? Shashank?
Yes, ma'am. Hello.
Yes, Shashank. Can you please place the first video?
Then it's a new imaging biomarkers guiding DME treatment, right?
Yes, and the next one will be Dr. Hemant ready with that as well.
Okay, fine, ma'am. I'll pay it.
Everybody, today I'll be speaking on the imaging biomarkers in DME. I have no financial disclosures. Now, diabetic macular edema is a very, very common cause of blindness in people of the productive age group. We all know that it can develop in both type 1 and type 2 diabetics. And about 8 to 13% of diabetic patients develop DME with visual impairment. Now, DME prevalence up to 15 years of diabetes was seen in 20% of patients with type 1 and 25% in patients with type 2 diabetes taking insulin. So therefore, it is dependent on not only the type of diabetes, but also the type of treatment they are on and the duration of the disease. Now, initially, beyond our clinical examination, fundus photography was also an indicator for us diagnosing the patient and also planning treatment, whether it was mild, moderate, or severe DME. Then came the clinically significant macular edema as defined by the ETDRS, which again had a little bit of ambiguity because you have to be very, very good in your clinical skills. We then had the fundus fluorescent angiography age. You can detect, small or subtle early changes of proliferative diabetic retinopathy, which could have been missed clinically. So why do we need a biomarker? Because there are no methods to prospectively determine which patient will gain or lose vision. There is a need to individualize the risk assessment so that we can plan our treatment accordingly. We need a non-invasive, readily obtainable imaging option, and imaging biomarkers can help us personalize treatment, therefore reducing the burden of the same. Now, this is the OCT as we all know now. We can see retinal structural alterations, we can see ultrastructural alterations, microangiopathic changes, choroidal changes, and vitromacular interface changes. Now, coming to diabetic macular edema, when we look at OCT, we see a spongy or diffuse thickening. We can see cystoid macular edema changes. We can see a serous retinal detachment without VMT, and we can see VMT without TRD. And finally, we see VMT with TRD. Now, why are each of these different morphological patterns important is because the treatment changes with their pattern. Now, those were some of the earlier criteria. What is it that we have new? We have hyperreflective dots or hyperreflective foci or HRDs. They are well circumscribed particles, 20 to 40 microns in diameter, equal or higher reflexivity than the RP band. So that's a good comparison. The origin is unclear whether this is associated with extravasation of lipoprotein, whether they represent degenerated photoreceptors, or they're activated microglial cells caused by intraretinal pro-inflammatory state is really not very clear. But if you look at these images, you can very well see them. There are few in the first image when they're less than 10, moderate when they are 10 to 20 in number, and many when they're more than 21 in number. So this is a IOVA's paper of 2017, which looked at the association between hyperreflective dots and spectral domain OCT in macular edema. For eyes that responded to a dexamethasone implant had more numbers of HRDs, and eyes with several HRDs are therefore probably having an inflammatory pathology that might contribute more to the edema as well. And macular edema with many HRDs may be more amenable to anti-inflammatory drugs than anti-VEGF per se. Now, next we're talking about DRIL or disorganization of retinal inner layers as a predictor of visual acuity. This is a study that was published in JAMA 2014. So when we look at DRIL, we are looking at the ganglion cell layer, the inner plexiform layer, the inner nuclear layer, and the outer plexiform layer. So when DRIL is present, it's actually a definition of horizontal extent in microns for which any boundaries between the ganglion cell and the inner plexiform complex, the inner nuclear layer and the outer plexiform layer cannot be identified. So the association of DRIL extent with visual acuity change was more consistent and robust marker than any other ST-OCT parameter. On an average, with the central 1 millimeter wide area of the fovea, for every DRIL increase of approximately 300 microns from the baseline to 4 months, visual acuity reduced by 1 line compared with the baseline. Disruption has been hypothesized to result when bipolar axons snap when their elasticity limit has been exceeded. Now going on to the ISOS integrity. In this image, you see that the ISOS layer is regular and continuous. In this, you can see partial irregularity, and finally, you see complete discontinuity in the last image. So the presence of SRF, the ISOS continuity, the absence hyperreflective foci, and an attached vitromacular interface are biomarkers that actually predict better visual outcomes. Now let's look at some case examples. Here you see good parallelism, no DRIL. This is with response to treatment and then the final response. So at 6/6, the vision is still maintained with good treatment outcomes. So that means decreased edema, maintained parallelism of the inner retinal layers, preserved vision even after multiple injections in spite of photoreceptor layer granularity. Now this is case number 2. The parallelism is partially affected here, which means there is some amount of DRIL, improved vision because of a relatively good IRL parallelism in spite of foveal and middle retinal hyperreflectivity and photoreceptor granularity. This, you can see that the DRIL is extensive. You can also see an ERM here, 618 to 636 with worsening of vision post-treatment. So the DRIL and PRL damage to start with was seen, no improvement in vision despite absence of fluid, PRL changes at the last visit, but increased DRIL and ERM are the causes for non-improvement of vision. So parallelism is preserved, DRIL is seen in this image. You can see with treatment, the parallelism is preserved, visual acuity is improved, whereas with DRIL, you see that the visual acuity has not improved, it is 636. So 2 eyes of an individual, this is. Both of these belong to the same patient, poor vision improvement and poor response in DRIL eye. So OCT biomarkers that predict visual acuity outcome are parallelism, presence of SRF, ISOS continuity, hyperreflective foci, an attached vitreoretinal interface, hyperreflective material and location, and intraretinal cystic space configuration as well. Now going on to OCTA or OCT angiography, the FAZ is already altered even before you see any clinical changes or OCT changes. So you can see here the superficial and the deep plexus and how they correlate with the angiography. You can see micronisms. You can also see an altered foveal avascular zone. You can see the map across mild, moderate, severe, and PDR, where you see the dropout. Macular ischemia correlates very, very well on both the FA and the octa. And this is another patient where you can see increased FAZ, capillary rarefaction, and microaneurysm in the DCP more than the SCP. So diabetic retinopathy with macular edema, you can see altered FAZ again, both in the SCP and the DCP. The corresponding on-pass also shows well-demarcated zone of edema. More microaneurysms, larger FAZ, and low vascular flow density are all indicators of poor response to DME. Then there is an OPL and a DCP correlation. Disrupted OPL and DCP non-flow areas correlate. Intraretinal cystic communication between the inner and outer nuclear layers correspond to the non-flow areas. So octa and DME, what are the difficulties that we have? The differentiation and segmentation is difficult. Projection artifacts can be there. Misleading features on the OCT are because of edema and hard exudate. To conclude, biomarkers in DME prospectively determine which individuals will respond to available treatment option. They assist in therapeutic selection and reduce the impact of invasive and burdensome treatment. Thank you so much for your patient hearing.
Thank you, Dr. Chaitra. I should thank you for an very lucid and clear talk on a lot of these biomarkers which are of interest recently. Thank you for an excellent talk.
Thank you, sir. Do you actually, which is your favorite biomarker, sir? Let me ask you.
I look, some part of it is the drill, some part of it, the hyperreflective foci and the continuity of the outer, the ellipsoid zone. So all that I do see sometimes. But I think all said and done, each one responds equally to either of the group of drugs. So it's always very difficult to say whether we would change our line of management or that. But I think your point is well made that visual outcome, it depends on all these factors. So I think you can predict or prognosticate the visual outcome in some of these patients.
I guess that's the most important thing here. The take home here is not that, even if you see HRDs, you will go ahead with steroids, but that doesn't make a difference as long as the patient is taking treatment. But when to stop treatment, when to tell them that, this is bad, your PRL loss is there, you're not going to improve, I think it's more important. And another thing that I particularly look for is the severity of the edema actually when I'm deciding treatment, rather than giving probably monthly injections when I know for sure that the patient is going to need more than 2 or 3 injections. Maybe then going to Ozurdex also makes a difference, because cost-wise, follow-up-wise, it becomes a little more easier for them. Guru Prasad sir, what about you? Do you also give a lot of importance to these biomarkers? Sir, you're muted, sir.
You're muted, Guru.
Yeah. All the biomarkers that you mentioned are equally important. Congratulations on that very good talk. It was a very good compilation of all the facts that we have to look into while treating a patient. I think outer retinal layers are as important as drill. The continuity of the ELM, the EZ, the RP atrophy, everything else also is important. Drill, I would like to ask you a question on drill. Whether drill is to be measured before treatment or after treatment to know the status of the retinal health. What do you think it should be the timing of measurement of drill?
So more measurements, we're only looking at qualitative, sir, because really in a busy OPD, none of us have, the patients to look at the calipers. So overall, we're looking at how the drill is, whether it is present or absent primarily. We are not measuring it the extent much. I would say more pre-treatment, sir, to tell the patient that because you have this issue, I'm not sure how much you will respond. Not that you will not respond at all, but whether it actually qualifies into visual improvement or not, because you will be showing an edema. If you saw in some of the cases, the edema is resolving, but the quality of vision is really not improving because of the drill. So pre-treatment, just to tell the patient, post-treatment, we have looked at some of the scans to see whether there is restoration of or a reversal of drill. We have not seen a major change, sir. So I would see more pre-injection than post.
I think it's more for prognosticating what's going to be the response then.
Right, so thank you both for the inputs. I think we'll go over to the next topic. This is my favorite topic that sir gives on whether anti-VEGF suffices for PDR. Over to you, sir. Can you please play Dr. Hemant Murthy's video?
Yes, ma'am.
And next, please be ready with Dr. Guru Prasad. This is on DME for patients with good vision. He's uploaded it today.
Okay, okay, sure. I'll look through.
First of all, I would like to thank KOS for giving me this opportunity. Sorry, Dr. Chaitra, I forgot. I would be speaking to you on, should we now treat patients with PDR with anti-VEGF agents? This is a patient of PDR who has been treated with PRP, and you can see the regressed neovascularization. Note, however, there is the extensive destruction of the retina as a result of PRP. And is PRP the perfect solution in PDR? We know that there is permanent peripheral field loss, there is decreased night vision, there is worsening of DME, and even with timely PRP, about 5% of patients experience severe visual loss. These are some images of patients of PDR who have been treated with PRP. Though the PDR is stable, one can see the destruction of the retina as a result of the PRP. So in view of this, there was a greater interest with the use of anti-VEGF agents. And one of these first studies was the protocol S, which looked into panretinal photocoagulation versus intravitreous ranibizumab for proliferative diabetic retinopathy, which was an RCT. They did observe in the short term, that is at the end of 2 years, the mean change of visual acuity score was plus 4.5 letters as opposed to minus 0.3 in the PRP group. And 53% patients in the PRP group received ranibizumab for DME. However, only 6% of patients in the ranibizumab group had PRP. The ranibizumab group developed lesser field loss and DME. They also observed that the probability of PDR worsening was 42% in the PRP group compared to 34% in the ranibizumab group. And the worsening was greater in eyes which had a worse diabetic retinopathy severity score. That is, patients with high-risk PDR showed 64% of patients in the high-risk PDR group showed worsening as compared to 23% in the moderate PDR, which was statistically significant. Worsening was also more frequent in those treated with pattern scan laser than single spot laser, 60% versus 39%, which was also statistically significant. So these were the factors that they studied when they managed PDR with anti-VEGF agents. The 2-year probability of vitrectomy was greater in the PRP group, 17%, compared to ranibizumab, which was 5%, which was also statistically significant. So in view of all these advantages, there was a great interest in the management of PDR with anti-VEGF agents. However, at 5 years, they found that the mean visual acuity score at 5 years was not different in the two groups, though the patients receiving ranibizumab had lesser occurrence of DME and visual field loss. The number of injections reduced from 1 year from the year 1, but on average required 3 injections every year thereafter. So these are certain points that one has to remember if we decide to use anti-VEGF agents. There was a study which looked at the combination therapy, and they found that anti-VEGF combined with PRP showed complete regression of neovascularization in 92.7% patients compared to 70.5% in the PRP group. So based on the 5-year results, the authors who studied the cost effectiveness of anti-VEGF agents versus PRP, they found that at the 5 and 10-year horizon treatment with ranibizumab, it was found to be cost effective in the US if it was associated with DME and not without it. There are some other ongoing trials, the DRCR Protocol W, the Panorama trial, which is looking at use of anti-VEGF agents in the NPDR. And they found that, preventive treatment did not confer any visual acuity benefit compared with observation and treatment with anti-VEGF agents after the development of PDR or visual reducing DME. There are studies being done to look at whether monotherapy or combination of anti-VEGF and PRP would be better than individual treatment alone. In view of all these studies, American Academy of Ophthalmology preferred practice patterns looked at, based on the available evidence, they said that it would be reasonable to consider use of ranibizumab in severe NPDR in settings where laser surgery would be considered, and in high-risk PDR, an anti-VEGF could be an alternative to PRP in those patients who can regularly follow up, especially if there is macular edema. They also looked at certain situations wherein anti-VEGF agents could be considered as first line, especially in patients wherein there is media opacity due to cataract and non-clearing vitreous hemorrhage. The ASRS also looked into the role of anti-VEGF agents in PDR, and they said PDR without DME traditionally has been treated with PRP, but now there is strong evidence that anti-VEGF treatment is a non-inferior option. Currently, there are strong suggestions for incorporating anti-VEGF agents include concurrent visually significant DME, and there are strong suggestions for incorporating PRP include inability to close follow-up and or not wishing for frequent long-term injections. This, I think, is the primary reason why I believe at present PRP is still the most cost-effective treatment in PDR in our patient population. And in our population, which has poor follow-up, I feel PRP still has a great role to play. Having said that, I think there are certain situations wherein anti-VEGF agents could be used. In patients who have got DME and PDR, one could use that as your primary treatment. Or a patient who has got PDR with a single neovascularization and has got a 6x6 vision, it could also play a role. Here is a patient who has cataract with mild vitreous hemorrhage and PDR. You could use anti-VEGF agents in the management in the initial phase till cataract surgery is done and one could safely do a PRP. Thank you.
So nice talk, as usual, very, very crisp. I think you didn't even use your entire time. So you made a point across very strongly. Sir Guru Prasad, sir, quick question. How many patients of PDR are you treating exclusively with anti-VEGF? I don't think any of us are. I think the one person who told me who's Indian and who's now treating with monthly anti-VEGF is Jay Chablan. But of course, he's not on these shores anymore. He said, I've stopped doing PRPs completely. And like sir mentioned, because of the lack of follow-up, it's going to be extremely difficult for us to, probably give only anti-VEGF. I remember a couple of years ago, Dr. MPS had told that because the patient was a doctor and didn't want to lose, visual field, he wanted only anti-VEGF. But even now there is a change in that, because even anti-VEGF can bring down the visual field. It can affect the visual field in long term.
Right.
So I think, and more importantly, we cannot afford anti-VEGFs on the long term.
So the two downsides that we have is repeated injections and close follow-up, which is not possible in our population. And the PRP is so cost effective that you cannot just compare the two groups. It's just impossible to compare. And you would always be happy. You do PRP once and you follow them after 5 years, 10 years. Patients are absolutely stable. That's you just have one look, it looks very good. That's the advantage of PRP.
And I think it's important to do a good PRP, not a scatter, especially because when your patient may not come back. We see a lot of patients coming back with just a scatter PRP. That's not adequate. I think a good PRP is any day, long-term benefits for our patients. Thank you so much, sir, again for the talk. We'll go over to Dr. Guru Prasad's talk. He'll be speaking on management of DME in patients with good visual acuity. Over to you, sir. And can you please play Dr. Guru Prasad's video? Next, please be ready with Dr. Sachin's video.
I thank the KOS for this wonderful opportunity to be a part of this IC, and in particular, I would thank Dr. Chaitra Jaydev for this, for involving me in this beautiful instruction course on diabetic retinopathy. Um, so, diabetic macular edema is a huge burden on society, and with the most common microvascular complication of diabetes, that is diabetic retinopathy, that it is expected to remain as a global threat to vision and economy. Diabetic macular edema is now the most prevalent vision-threatening form of diabetic retinopathy, especially in patients with type 2 diabetes mellitus. The treatment options that we have in our armamentarium today is, besides systemic control and control of other risk factors, laser, anti-VEGF, steroids, combination of the above, and subthreshold micropulse laser. The most widely used are the anti-VEGFs and steroids. So why are we discussing this today? Treatment is often on a regular basis and is of long-term duration. Many countries, including ours, are struggling to cope with the rising number of patients. The treatment burden could be compounded by clinicians who might be tempted to use the current evidence to assume its efficacy beyond proven clinical indications. One such questionable indication is center involving diabetic macular edema with good vision. So what do we actually treat in a diabetic retinopathy patient? The accepted thresholds for initiating treatment of diabetic retinopathy are center-involved diabetic macular edema with visual acuity impairment, and number 2 is proliferative diabetic retinopathy. So all studies enrolled eyes with an ETDRS best corrected visual acuity letter score of 73, that is 20/40 or worse. The DRCR network advanced this upper threshold to 78 letters, that is 20/32 in their protocols I and T. Within the AntiWedge era, the DRCR network protocol V has the first prospective data set to provide management decisions with macular edema and visual acuity better than 20/30 or 20/32 or also known as good visual acuity according to them. And my talk will be based on the data of protocol V. So with an OCT, diabetic macular edema can be divided into eyes with non-center involving and center involving diabetic macular edema. So what is this protocol V? The design is like this. All patients with diabetic macular edema with a vision of 20/25 or better, there were 702 of them in 91 centers spread across North America, and they were divided into 3 arms: aflibercept 2 milligrams, laser, and observation. And the primary outcome measure of was loss of 5 letters or more at the 2-year follow-up. The results, we can see that 16, 17, and 19% respectively in the aflibercept, laser, and observation groups had loss of 5 letters or more. That was all that was the loss. And aflibercept was used when vision worsened in the laser and observation cohorts as rescue. The need for aflibercept rescue was more in the observation group than the laser group. And the mean visual acuity at 2 years, it is heartening to note, was 20/20 in 77%, 71%, and 66% in the 3 arms respectively at 2 years. So collectively, these data suggest that it is generally safe to initially observe center-involved diabetic macular edema with good vision and consider treatment only when visual acuity impairment occurs. So what good has this study done to clinicians? It illustrates the importance of identifying whom not to treat in the era of increasing use of anti-VEGF therapy for proven and unproven conditions. It allows clinicians to feel safe to adopt a more conservative approach in the management of these patients with good vision. From a global standpoint, it would be estimated that about 11 million adults with diabetic macular edema, that is 40% of the 27 million people with diabetic macular edema with good vision, would need nothing more than just observation. About 2/3 of these patients may never require anti-VEGF therapy at all. So the fresh algorithm for management of diabetic macular edema, you can see the flow chart. If it is center spared, probably macular laser therapy is sufficient. If it is center involved and the vision is good, then again observation could be a very good option. But if the vision is involved or the vision is impaired and the central macular thickness is more than 400 microns, then probably anti-VEGF therapy has to be instituted, and any treatment failure has to be treated with anti-VEGF therapy. In view of these data, what should we do for our patients with DME? This is a real world question. There are basically three scenarios. For patients with visual loss due to center-involved DME, anti-VEGF therapy should be continued. For patients with center-involved DME and good vision, they can be initially observed, and anti-VEGF therapy can be offered when visual impairment occurs. For patients who are keen to reduce the risk of needing anti-VEGF therapy, macular photocoagulation can be considered. For patients with clinically significant macular edema not affecting the central macula, macular laser can be considered to reduce the risk of vision loss. But we can see that progression rate is very low. It's just about 14% in 1 year from non-center involving to center involving diabetic macular edema. So actually, laser also can be deferred. Clinical trials versus real world is something which we have to look at. Although data from clinical trials are helpful, clinical management of diabetic macular edema should be based on discussion with each individual patients according to other factors such as systemic control, peripheral diabetic retinopathy severity. For example, if there is proliferative disease, the treatment may vary, visual symptoms and needs of the patient, and the fellow eye status. Certain questions the protocol we studied did not answer. One of them is what about uncontrolled diabetes? Because most of the enrolled patients had a mean HbA1c of 7.6. The mean CMT also was quite low in these cohorts, 306, 314, and 314 microns respectively in 3 arms at baseline. And whether this is good enough to watch patients with more severe DME of more than 400 micron thickness with good vision is uncertain. A small but significant effect of prompt laser therapy was also documented as compared to initial observation, but the cost effectiveness analysis was not done. The quality of vision and quality of life was not taken into consideration. Lines and letters are only quantitative and not qualitative. The absence of challenge and stress of the frequent visits and injections would have a positive impact on the patient's quality of life. This is for certain. This is particularly relevant to diabetic patients with their possible comorbidities. And whether leaving diabetic macular edema beyond 2 years is safe or whether it would affect the response to laser treatment is something that it did not answer. The previous studies, especially the VIVID and VISTA study, have shown that treatment later after failure of laser therapy was not as good as when treatment was given upfront at the beginning of the trial itself. So what should be the follow-up interval of these patients is another thing that is questionable. That's a question that is unanswered. It varied between 4 weeks to 13 weeks in across various studies, and therefore these low-risk patients do not have an actual optimal follow-up interval guideline. Arguments in favor of treating eyes with good vision. Number one, ETDRS had 2,200 eyes with good vision, 85% of them with 20/40 or better, and 63% of them having 20/25 or better. And the CSME treatment reduced the probability of visual acuity loss with laser. Treating center involving diabetic macular edema with vision loss earlier leads to better outcomes at the population level, and VEGF blockade appears to have the capacity to alter the diabetic retinopathy severity scale, which is something good to know. But the arguments in favor of delaying treatment until visual acuity loss occurs is something that we are looking at today. Lack of data demonstrating that earlier treatment leads to meaningful difference in visual outcomes is one of the reasons. Cost and burden for patients and the healthcare system is probably the main reason. And the risks of treatment itself is something we have to be aware of. So in summary, we are more confident in conservatively managing our patients with center-involved diabetic macular edema and good vision. The initial observation without any active treatment is a reasonable choice. Good vision can be maintained as long as they return for regular follow-up visits. The data may serve as a reminder that treatment must be judicious for the right reason and right patient. The future for DME with good vision, there can be development in future of more durable treatment options and less invasive approaches, may affect the present thresholds for treatment, and such thresholds may need to be tailored according to the individual biomarkers. Thank you once again. Thanks, KO.
Thank you, sir. Very nice and interesting talk, actually, because we do see so many patients with good vision. So I have one question for each of you, actually. Guru Prasad, sir, what is your cutoff as far as the edema goes. Now, suppose you have a patient with very good vision, and we don't really do ETDRS letters, so we most like do only Snellen's. So, what is your vision cutoff on Snellen, and what is your CMT cutoff to treat a patient with good vision?
I would not take the CMT alone as a criteria. I would probably keep the 350 as an arbitrary cutoff, but take into consideration the patient's symptoms. He might be reading 6/6 or 6/9, but that doesn't mean that his vision is not lowered. I was talking about the quality of vision for these patients. They might say that they have blurring, they have difficulty in reading, they have reduced contrast sensitivity, they have difficulty in driving at night. So all these things have to be taken into consideration before we actually choose a treatment option. I think one cutoff point is not enough. We have to have several cutoff points for treating diabetic macroedema with good vision.
Dr. Hemant Murthy, sir, how many patients have you seen wherein you have advised patient injection and their sugars are not controlled, and by the time they come back after controlling their sugars, the edema is gone?
I have some patients. Actually, I tell my fellows now that you check their systemic status. If it is bad, just give them some time. They actually do well. They improve a lot. So you would have a much lesser amount of problem to treat with anti-VEGF than you start initially. And I fully agree with Dr. Guru Prasad. See, I always ask the patient symptoms. If they're asymptomatic, then I think I leave them, because they need to have some symptoms to deserve a treatment, because our treatment might also lead on to certain problems. So let us not make it inconsequential. There's always some element of risk that one needs to take when we do anything.
I feel when a patient quality of vision is affected or the patient is symptomatic, it's easier to convince them about the treatment. It becomes very difficult to convince them for treatment based on an OCT scan alone. When you show them the OCT, the patient says, I'm perfectly fine. And like sir says, God forbid you have some complications. For a person who had absolutely no symptoms, you cannot justify it. So I think points are very well taken. We can forward to the next talk now. Thank you so much. Next, we have Sachin will be talking to us about surgical management of DR. Can you please play his video? And please keep Dr. Bhujang Shetty's video ready next. Back-end team, please.
Okay, sure, ma'am.
Sachin, we'll have your talk now. Please play the video. Thank you.
Yeah, sure. Thank you. Everyone, I'm Dr. Sachin Mawli. At the outset, I would like to thank KOS, my entire team of COSCON for arranging a wonderful virtual meeting. I'd also like to thank Dr. Chaitra Jaydev for involving me in this wonderful IC. Well, today I'll be discussing about surgical management of diabetic retinopathy. These are the main three topics which I'll be covering in my talk, like what are the indications, what is a pharmacotherapy aided surgery, what are the tools and techniques which have changed recently and which are aiding our vitreoretinal surgeries for diabetic retinopathy. These are mainly the evolving concepts which are coming up for diabetic retinopathy nowadays. Like we tend to err on more early vitrectomy. Talk about indication. The most commonest indication for vitrectomy in a diabetic retinopathy would be a vitreous hemorrhage, which would be most commonly we would advise vitrectomy in cases which are non-clearing vitreous hemorrhage. Like for this case in the video you're seeing, it's a non-clearing vitreous hemorrhage for a very long time. Dense preretinal hemorrhage is another indication because subhyaloid hemorrhages take very long and they won't clear up very quickly. Tractional complications like TRDs involving or threatening the macula, combined retinal detachments, severe fibroscular proliferation, subretinal membranes causing vitromacular traction, macular hole associated with the tractional component. If there is a tractional diabetic papillopathy, is again an indication for vitrectomy. Tractions causing diabetic macroedema is also an important indication for vitrectomy nowadays. Other indications like very dense asteroid hyalosis, which is preventing from PRP, hemolytic glaucomas, early NVGs, and intraocular proliferation are relative indications and definitive indications for the diabetic vitrectomy. A case like this with macular edema with a taut posterior hyaloid definitely would be an indication for vitrectomy, because these cases won't respond to any anti-VEGF or your steroid treatment. When you do a OCT, we find very taut posterior highlight causing, vitreomacular traction and impending macular holes. These are definitive indications for vitrectomy nowadays. Coming to tractional lateral detachment, extramacular TRDs may not be operated in all cases because the risk of progression to the macular involvement is less than 14%. Based on the size, again, various studies have come up with the TRD progression like 18% if it is less than 4 disc diameter, if it is 31% more than 4 disc diameter. Certain things have to be kept in mind when we advise surgery for diabetic retinopathies, like with poor visual prognosis. If the retinal detachment is long standing, if you see a thin atrophic retina, then we should explain the poor visual prognosis, and you should be very careful in advising surgery in such cases. If the optic disc looks very pale, if you see a lot of sclerosed vessels, major vessels, if you're seeing very sclerosed and atrophic, then then definitely these cases would have a poor visual prognosis. So when do we consider early vitrectomy? Type 1 diabetics, usually we consider early vitrectomy because studies have shown that better visual outcome with early surgery. If there's a presence of rubiosis, vitrectomy actually helps us do a retinal ablation intraoperatively and reduces the risk of NVG. If the poor eye status is very bad, or if you've lost an eye because of diabetic retinopathy, definitely we would like to advise early vitrectomy in such cases. If the case has bilateral vitreous hemorrhage, again an indication for early vitrectomy. If there's a presence of combined retinal detachment, is also an indication for early vitrectomy. Now, coming to the pharmacotherapy aided surgeries, especially I would like to mention about the anti-VEGF agents which we give in pre-operatively, ideally given 4 to 5 days before the surgery. How do they help is basically by minimizing the intraoperative bleed. They alter the planes and help us in dissecting better membranes. One thing we have to always remember in such cases is medical fitness need to be obtained beforehand, because if you give an anti-VEGF and don't operate, then there's something called crunch effect, wherein the fibrosis become very hard, and later on when you plan a surgery can be disastrous. Recent studies have come up with Lex Implant being used as a pre-operative tool, wherein it helps in the regression and consolidation of fibrosing proliferation in a very high risk PDR. It's usually given in the vitreous base before the surgery. It's also anti-inflammatory based. It reduces the cytokine, and better postoperative control of inflammation is seen in these cases. It also is said to reduce the reborn neovascularization, which usually occurs after vitrectomy in certain cases. This implant also works better under the oil as well. Coming to the surgical tools and techniques which have changed largely in last 5 to 6 years, we have now walled cannulas to better control of intraoperative hemostasis. We have better cutter technologies wherein the smaller gauge cutters can work very close to the retina. We'll be coming to that. We have wonderful light source to illuminate the vitreous very well. We have chandelier light sources for bimanual dissection, which is a wonderful tool. Viewing systems have been changed and have been really aiding vitreoretinal surgeons in a very big way. We have wide angle non-contact and contact viewing systems, which give us a panoramic view of the retina and helps us understand the vitreous anatomy much better. HD viewing systems are helpful in dissecting the membranes and very close to the retina. Recently, 3D viewing systems have been helping vitreoretinal surgeons operate heads up, and it's a wonderful training tool wherein you can teach your colleagues how surgery would be performed in real time. Coming to the small gauge vitrectomies, recently 27, 25 gauge vitrectomies have been becoming a norm to use for diabetic retinopathy. These cutters have multifunctionality. It's easy and very close to retina. We can work. I'll show a video about it later on. These have better surgeon control and user interface. Role of OCT. Preoperative OCT has made understand diabetic retinopathy in a better way. We understand more cases of vitreomacular adhesions and vitreomacular tractions, adding on to the indications for surgery. Intraoperative OCT is a recent addition, and definitely helps in dissecting the planes, and we also can find intraoperative hole formation, macular hole formation, or if you're taking a case of dense vitreous hemorrhage, which pre-operatively you could not see the macula, intraoperative OCT definitely helps us understand the macular anatomy better. Coming to the surgical techniques, the various different techniques have been included and have been popularized recently, like in pushing techniques, where you basically understand the understand the attachment of the membranes to the posterior hyaloid. so that we can get a better plane of the membranes. Unimanual and bimanual surgeries both are used for diabetic vitrectomies. Unimanual surgery is basically using cutter alone, or you can use scissors and forceps, like in this video, wherein the multifunctionality of the cutter is seen. Cutter is used to delaminate the membranes and segment the membranes into smaller islands. Basically, the cutter has, this video is showing cutter as a multifunctional tool, wherein you don't have to use scissors and delaminating spatulas, where the cutter itself can act as a spatula and a scissor. This video actually shows how a cutter can be used as a multifunctional tool. Basically, this is a case of proliferative diabetic retinopathy with tractional retinal detachment, which has subretinal hemorrhage also. What I'm doing now is inducing the cutting the posterior hyaloid. It's called truncation of the cone. Once I cut the posterior hyaloid, you can see the subhyaloid hemorrhage comes in the cutter, clearing all the subhyaloid hemorrhage. Once you clear all the subhyaloid hemorrhage, you have a better visualization of the membranes. This technique is called hydrodissection of the posterior hyaloid, wherein I'm using proportional reflex from the cutter to hydrodissect these membranes. We push a gush of fluid under the subhyaloid space so that we can get a better cleavage, so that we can cut the vitreous properly in a perfect plane. This actually helps us dissect the membrane also. As you can see, we get a better taut adherent posterior hyaloid can be separated by this hydrodissection technique. So again, this shows how close we can work to the retina. We can go very close to the retina with cutter being used as a spatula in this case, and also as a scissor. So just to summarize how we manage diabetic retinopathy: if there's a vitreous hemorrhage, if it is non-clearing, advise vitrectomy. If it is getting better, you would do a PRP or an anti-VEGF injection. If it is uncomplicated PDR, directly go ahead with the PRP and the anti-VEGF if required. If there's a TRD, or depending on whether it's peripheral, you want to watch. If it is involving the macula, if it is severe, you go for pharmacotherapy aided vitrectomy. If it is moderate proliferative vitreoretinopathy, then you can directly go in for vitrectomy. So basically, the take-home message is better instrumentations and anti-VEGFs have changed the surgical success to a very great level. Better understanding of vitreomacular interface, OCT, have widened the scope of predictable results. Earlier surgery has mostly become a norm, make surgery easier and better visual results. Thank you very much for your patient hearing.
Thank you, Sachin. Very, very well put together. You know, you've covered everything from surgical tools to indications to pharmacotherapy, everything. I think very, very well put. I have a quick question to Dr. Hemant Murthy, sir. PDR, I think, we do know that surgical options remains the best. My question to you is, do you go ahead with surgery for macular edema to prevent the unending, injections, even if there is no traction? Of course, if there is traction, yes, well and good, we will do it. But without traction, what is your take home or your take on basically whether you want to do vitrectomy for patients with chronic DME or recurrent DME?
Actually, what I did is I have done a study on this. Actually, I did try out doing vitrectomy for these macular edema, which is non-tractional. I did in one group tractional macular edema and one which is non-tractional macular edema, and I found that those with non-tractional macular edema, you do get a resolution of edema, but no improvement in vision. So ultimately, it doesn't make difference to the patient. So they end up with the same level of vision that they had. So I don't think surgery is a good option, especially in that situation. You get a good OCT, but that doesn't matter for the patient.
I think that's true, sir, because a lot of patients with diabetic vitrectomy, even though we have peeled the ILM many times, they do come back with a little bit of edema. It's not like they don't come back with edema at all. That is when I find it a challenge. So what is your post-surgical treatment, Sachin? Suppose you've already operated a patient for PDR and the patient comes back with macular edema post-surgery. What is your pharmacotherapy preference for patients with oil and patients who do not have oil?
See, basically, with oil, I don't think Ozurdex would be an option. It does work well. Many reports have said, but I mean, my personal experience, I have not given any Ozurdex with oil. Probably it will be anti-VEGF again for both the scenarios, even with or without oil. So if there's a macular edema which we see post vitrectomy, and if see this can happen mostly when we peel the posterior hyaloid or a ERM, which is causing a edema, and the edema doesn't settle well. So then we may have to give an anti-VEGF to settle that edema, because earlier anti-VEGFs, whatever you've given, might not have worked because of the ERM or a macular traction which was there.
So what is your take, sir? Because I have used Ozurdex in patients with oil as well. In fact, I'm a little skeptical about using the implant in vitrectomized eye without any tamponade, because I'm so scared that when you're
True.
injecting, there's resistance from the vitreous. So I'm worried about the implant causing impact on the retina. What do you do, sir? Have you any thoughts on post vitrectomy treatment of edema?
Post vitrectomy, if I see macular edema in a patient with fluid, I do give Ozurdex. Only care that you need to take is, because you inject from the temporal quadrant, you need to see that you inject in such a way that you get the longest distance that you have, so that you don't hit any structure, and inject it slowly, so that it comes out not with a rapid gush. Whereas in those with silicone oil, I would use anti-VEGF. I don't use because I feel what happens is the volume of distribution of the drug tends to become very concentrated in the small layer of fluid that is present. I think that would not make it advisable. So I don't use it, although there are reports that it does work. I think with silicone oil, everything works. So it's not so much of a problem.
I have used. I think we need to publish more. We're looking at the use of Ozurdex in patients with oil-filled eye. It's not only DR related. Even post RD surgery, some of them, whether because of some vitreous that's left behind, we do see some cystoid macular edema in them. Even they seem to respond pretty well to the implant. The most important advantage there being that it stays longer. So we're having a sustained effect for 2 to 3 months, and the patient also is happy. So I think once we come back with reports of that, we'll know more. I think we'll go over to the next talk now. Thanks, Sachin. Excellent talk.
Thank you.
Next.
Thank you. Thank you so much. Yeah.
Next will be Dr. Bhujan Shetty. He'll be talking on reversing diabetes. Is that a possibility? And this is, shifting gears from managing as an ophthalmologist to probably a holistic approach to management of the disease, the underlying disease itself. Can you please play the video? It's called Reversing Diabetes. And please be ready with the last talk by Dr. Anand.
Reverse diabetes using what is called a low carb, healthy fat diet, which I feel is a very practical diet, which is easily doable, sustainable, and which has given great results. This is what I'll be talking about today. Well, now coming to diabetes, as you all know that it is exploding. In 1980, when I was a student, only 5% of the adult population of our country was suffering from diabetes. And in the last 40 years, it has gone up 4 to 5 times that. Can you imagine? And with all the advice that we have been following, with all the latest tablets and treatment, the diabetes is simply going through the roof. There has to be some problem. And you know that it's a downhill course, and following all doctors' advice and medication, still people end up losing their vision, losing their kidney failure, heart diseases, amputation, and the rest. And then we as doctors, as you know, in Narayan Netralaya at Rajajinagar itself, we have more than 200 of these patients coming every day to see 8 of our vitreoretinal surgeons, most of them with these problems, and they seem to be going downhill. And whatever said and done, we tell them, keep your diabetes under control, keep your diabetes under control. We tend to blame the patient. We say, look, you are lazy, you're not following the instructions, you're not doing enough of exercises, or it's your fault. We always blame the patient. But I feel the problem is elsewhere. Well, we all think that obesity, diabetes, blood pressure, all these are all different diseases. and we go to different specialists and get treated. Unfortunately, the root cause is the same. The root cause is carbohydrate intolerance. And this carbohydrate intolerance leads to what is called insulin resistance. What causes type 2 diabetes? There's no doubt. It is increased carbohydrates. The more carbohydrates we eat, the sugar spikes, blood sugar spikes. As the blood sugar spikes, the insulin spikes. And when insulin is high and you're constantly feeding your body almost every 2 hours, some amount of carbohydrates, the insulin remains very high. And invariably, we develop what is called insulin resistance. That means even though the insulin has gone up 3 to 4 times, it is not able to push the sugars out of the bloodstream into the cells, because the cells have become resistant, cells have too much of it, and it's saying, no, we can't take it anymore. This is the problem. This is what is called, you develop insulin resistance. But actually what we do nowadays is just test only the blood sugars. Blood sugars, by the time the blood sugar really shoots up, at least 5 to 10 or sometimes even 15 years earlier, the insulin shoots up by 2 to 3 times. So if you really want to catch a person early in a pre-diabetic stage, we need to test their insulin and not their sugars, because sugars, insulin will go up 2 to 3 times and keep the sugars down. When you test the blood sugar, it's in the 80s and 90s, but actually the insulin would have gone up 3 times. Insulin is working thrice more to keep that sugar down. So if you can catch that insulin is very, very high, that means the person is about to develop diabetes or he's a pre-diabetic, and we could take action then and there itself. And that is at least for 5 to 10 years before the person turns up. So now there is some amount of controversy. Some say sugar is the culprit. Some say, no, sugar, not sugar, it is fat the culprit. So there's been a war for quite some time between low carb and low fat diets. But let me tell you, friends, the facts now. Well, you all know how the insulin responds to different macros. When you eat a sugar or carbohydrate, maximum insulin response the body has to any carbs. Whereas to protein, it's almost half that, and almost negligible amount when you eat fats. So if you want to really bring down your insulin levels or what is called insulin resistance, the only way to do is reduce your carbs and increase healthy fats. Well, this is the diet that I'm talking about. What we need to do is reduce carbohydrates, especially the sugars, to less than 10% of your total calories. And proteins are absolutely essential. So maybe 20 to 30% proteins. You cannot cut down on proteins because you need strong muscles and bones. So proteins are essential. There is this, it's a switch between carbohydrate and fat actually. Once you reduce your carbohydrates, you'll have to replace that with healthy fats, not any fat. Well, now coming to the practical aspect. So what are the things you need to avoid? Sugar. Sugar is culprit number one. There is absolutely no doubt on that. And it is accepted universally. There is no question mark. Well, sugar is toxic. Sugar is slow poison. Sugar is addictive. I must tell you that sugar is more addictive than smoking, alcohol, or even drugs. That's why, although so many of us know that sugar is bad, we just can't leave it because we have all become addicted to sugar. Well, then what you can have? I told you non-starchy vegetables, and for non-vegetarians, you can have meat, fish, eggs. Absolutely no problem. But healthy fats you have for vegetarians, you have butter and you have ghee. And coconut is one thing that all of us love. It is so tasty. You can have it in the form of chutney or curry, and even oil is very healthy. Although people say that it has saturated fats, definitely not. There's no connection now, scientifically proven, that between your saturated fats and cholesterol and heart disease has been shown. Olive oil is another oil that can be regularly used. And if you want to snack, you can have all the nuts, but not dried fruits. And among fruits, you could have berries. They have the least amount of sugar. Avocado is considered as a miracle fruit. And it is one of the best things that nature has provided us. And that's one fruit that we can have in plenty. But whatever said and then, all this you must get it as natural, as organic as possible. Well, then you will say, how do I get my dosa, idli, and rice, and chapati and all that? I mean, used to this. You say, give up everything. Well, there are ways to do it. They say, if you're out to beat a dog, you'll surely find a stick. Well, now you have got what is called cauliflower rice or broccoli rice, or what's called fake rice. And over that, use whatever curry you want to, with all the vegetables you want, and then your stomach is full. So what happens when you change your diet? Of course, you take a little step, but assist with it. First thing that happens, and what I noticed also, your appetite, your hunger, your craving decreases. This is the best part of a healthy fat diet. It is so satiating. You don't want to eat all the time. All of this, you may say, my God, can one thing stop all these problems? Yes, I told you earlier, there is one root cause for everything. You remove it, and all your so-called metabolic diseases will simply disappear. So far, I've given you some facts and figures, but as I say, facts and figures don't change behavior. Sometimes stories do. So I'll just take another minute or two, tell you exactly what happened to me. I was declared a diabetic when I was 40, and I kept taking tablets. And as I visited doctor every year, the number of tablets kept on increasing. And doctor even put me on insulin for a year or two. Yeah, along came my bad cholesterols, my heart problems, my kidney issues, my creatinine went up. At the end of 25 years of diabetes, I was taking almost 12 tablets every day to control each one of them. Then I hit upon what's called this low carb, high fat diet. And believe it or not, within 2 to 3 weeks of switching over, my triglycerides came tumbling down. It was below 100. It was actually around 300 at one stage. And the good cholesterol, HDL, went up, which I've never seen above 35 or 36 in my life. Now, I think last time when I tested it 3 months back, it was around 46. I must test this week again and see where I stand. And my weight came down further, and the remaining tablets for my diabetes simply disappeared. So what I'm trying to tell you is, first, shun sugars. There is no doubt about that. Restrict your carbohydrates, prioritize your proteins, and have healthy fats.
I don't think Sir was able to join. If anybody has any questions, I can take it. We're having a lot of personal experience here with some of our patients where we were able to reverse, their diabetes and stop their medications after starting this particular program that Dr. Bhujang Shetty spoke about. So if anybody has any doubts about this, how to go about it and what it entails, I'll be glad to take questions. In the meanwhile, I think we can go ahead with the last presentation, which is on AI-based screening for DR, and can it help us more? Can we have the video, please? Dr. Anand is currently in the US, so I think it's going to be difficult for him to join in. He's having some network issues, so we'll go ahead with the video, and if he can join in, he'll be able to take some questions. Please go ahead.
A very good afternoon. Thank you so much, Dr. Chaitra, for the opportunity to present on the prospects of teleophthalmology and artificial intelligence-led diabetic retinopathy screening. I'm the founder director of Remedy Innovative Solutions, and we have commercialized products and vision screening, including diabetic retinopathy. Diabetic retinopathy is indeed a significant public health challenge. As we all know, nearly 1 in 3 patients with diabetes suffers from diabetic retinopathy, and we have a very large patient load of nearly 400 million patients worldwide that need to be screened for diabetic retinopathy at least once a year. And the DR needs to be picked up much before the patient notices symptoms, at which point it may be too late. Now, large-scale diabetic retinopathy screening programs using retinal imaging have had demonstrated impact in literature. In fact, the NHS screening program for DR in the UK is one of those successful programs where retinal cameras were placed in general physician clinics, and using teleophthalmology over a period of 7 years, today the outcome is that diabetic retinopathy or maculopathy is no longer the leading cause of certifiable blindness in the UK in the working age group. But the question is, can this model be replicated in the developing world? What really are the challenges? One, at 40 pounds, it's too expensive to bring that model to India. So it's very important that the model be done in a manner that the cost per patient is possibly around 50 rupees or even lower. We also need the devices to be extremely simple to use so that not only nurse practitioners but public health workers can also use these devices if these are brought to public health centers. And finally, we need specialist readers or AI algorithms to ensure that grading can be done in situ. We built smartphone-based imaging systems that preserve high image quality and are very simple to use. These are portable and at the same time are 1/5 to 1/6 the cost of conventional cameras and are very easy to use and learn. These devices are different from other smartphone-based retinal imaging systems like those that are used with just a simple 20D optical design. Those usually cannot be used for non-mydriatic imaging, have corneal reflex artifacts, and at the same time also have Perkins reflex artifacts as well. Our optical design ensures that you get a very high quality image from these devices, similar to what you get from high-end systems, and no polarizers are used. The devices can either be carried on a backpack with a portable chin rest or can also be used in a handheld mode. We've had a number of independent clinical validations that have been done on the performance of the device, and it's been compared to the Topcon TRC50DX and Zeiss FF450, which are traditional desktop-based imaging systems. And we found that for all grades of diabetic retinopathy, the performance has been as good as what you get from desktop systems. Now, one of the things that we started working on is how do we bring offline AI algorithms that can be used without the need for any internet access. For example, these algorithms are responsible for auto capture, where in this case, as you can see here, the nurse practitioner only needs to place the plus sign at the center of the pupil and the device will automatically capture an image. This is very useful when the nurse practitioner or the health worker does not know how to get the right working distance, and automatically it captures an image without them having to necessarily trigger the capture. Similarly, we have enhancement algorithms that ensure that there is enhancement of the images and the gradability for the presence of diabetic retinopathy is done within 5 seconds by the algorithms on the device itself. We have now taken the Remedio Fundus on Phone device and we have screened nearly 7.5 million patients globally in 2,800 plus locations worldwide through either AI-based screening or teleophthalmology. We now present some of the successful models for diabetic retinopathy screening that we have done in India. The first is a mobile screening in schools and community centers. This was a model by the late Dr. Salil Gadkari, who used a wonderful idea of using local media and ads in local media along with NGOs to do screening. For as low as 110 rupees per patient, we were able to screen for diabetic retinopathy in 25 districts of Maharashtra. That includes the cost of the camera, diesel, van, and also the cost for the ads in order to do the screening. We have also done a community screening model in Mumbai with the BMC clinics. And here what we have done is taken youth from Dharavi with no prior experience in fundus imaging. And the AI algorithms were found to have very high sensitivity and specificity for the detection of referable diabetic retinopathy. And this in spite of the fact that the images were taken by someone with no prior experience in taking retinal images. We have also done a vision center based screening model, and in this model with Arvind Eye Care, an interesting study that was done is to compare two sets of vision centers, one that used fundus cameras and other that did not. And what was interesting to see was the fact that there was a threefold increase in the number of patients that were detected with retinal disease or early retinal disease in those centers that carried a fundus camera compared to those that did not carry a fundus camera. We've also done diabetic retinopathy screening in diabetologists' primary care settings in India. And Dr. Mohan's is one of the centers where roughly every year around 18 to 23,000 screenings are done using teleophthalmology. There's a 22% detection rate, including 7% vision threatening condition that is detected every year, and they are moved to care continuum. The return on investment for the diabetologist in this case happens in less than 1 year, and they also have revenues from treatment referrals. We've also done screening with the government and public health centers, and this was a model that we did with the Kerala government and Moorfield Eye Hospital at NHS. This was the brainchild of Dr. Shobha Shiv-Prasad. And what we were able to do here is to place the Remedio Fundason phone devices in 150 PHCs. And the initial success of the program, where we detected 31% of those with diabetes to actually have retinopathy, and we moved them to actually care continuum. We are now moving from teleophthalmology to AI-led screening, and the government is now investing to expand to 350 centers. One key learning that we had through this program was the importance of not only ensuring that we have testing centers, but these were also linked to treatment centers. And this ensured that the patient could go through the care continuum pathway and could go through the regional institutes of ophthalmology for either management of retinopathy or treatment of retinopathy. In the US, we've also done diabetic retinopathy screening at scale in primary care as well as retail settings. Here we use teleophthalmology, where 500 plus devices are placed in pharmacies, and in these pharmacies, when people come for their prescription refills, they also get their eyes checked at Walmart, and this results in them being able to detect for diabetic eye disease even as the blood work is being done or the pharmacy is being prescribed. What we've seen is the area of DR screening is evolving, where today we need national guidelines and a policy around DR screening. We need to engage provincial governments to take the success of the Kerala model and bring it to other public health centers as well. Awareness amongst patients with diabetes still needs work, as well as among primary care physicians. And we need to ask ourselves, how do we create an incentive model for the general physician who manages a diabetes patient to do this on a regular basis in India? Also, we need a reflection on the protocols, where in our opinion, based on what we've seen, we sometimes see PDR in a supratemporal quadrant. So there is need for dilated 3-segment examination rather than just simple non-mydriatic 1-segment examination or 2-segment examination. We are now moving towards wide field imaging technologies that can look at 7-segment of the ETDRS protocol in a single shot. At the same time, we are also looking at AI algorithms that are able to detect diabetic retinopathy, glaucoma, as well as AMD from a single image, the same image that is used for diabetic retinopathy screening. So we do believe that there is a significant opportunity to expand teleophthalmology and AI-led models in the war against preventable blindness due to diabetic retinopathy. Thank you once again for the opportunity, and look forward to answering any questions.
Is he online? I doubt whether he is.
He messaged me, sir. He's in the US actually. He was saying he's unable to join because of network issues, but I think it was an excellent talk.
Yes,
I mean,
yes.
so much
Actually,
promise.
we were part of the early validation of the equipment and the AI. So we had actually done the initial part of the AI development, because we were associated with the validation program on whether it is up to the standard that was needed. So we have done about 2-3 studies with him on diabetic retinopathy, and that was in conjunction with the Dicon Hospital, and we could do the AI is developed from person in Singapore, so we use that AI to find out how it is. It was very good. We actually found out what would be the best number of images that you need, whether you need disc centered, macula centered, whether it should be a single image, whether we need 3 images. That is what he was talking of. Now we did all that to find out what would give us the best result.
So I think one big fear that doctors have regarding AI is, are we going to be replaced? I don't think that's going to happen. That will probably make life a little easy for us. But I think as far as the empathy, the treatment, and the counseling goes, I don't think we can be replaced. And I think on that note, we've finished our IC. If anybody has any inputs, will be really good to take it from you if any questions. Otherwise, I would like to thank my co-instructors. This was one of the first ICs we have done where we've had a combination of talks. non-medical AI. We've had some surgical talks, medical laser-related talks. So I'm hoping we were able to do justice about the new concepts with regard to management of diabetic retinopathy per se, and also DME in particular. Thank all of you, and very nice talks. I'm sure you agree that each one of them had wonderful inputs for all of you. Thank you so much, and thank you to the organizing team for having selected our instruction course.
Thank you, Chaitra. I think it was an excellent IC. Good topics. I think a lot of interest. Thank you very much.
Thank you, sir. Thank you, Guru Prasad, sir. I know your throat is bad, and thanks for recording nonetheless. Take care, and thanks, everybody.
Thank you, ma. Thank you. Bye. Bye.